Good evening. Welcome to Bite-Sized Learning, and I am your host and moderator, Dr. Mike Sevilla, President of the Ohio Academy of Family Physicians. We have a great and important topic tonight. Navigating this opioid crisis that we're in. Obviously, that's been more on the back burner just with all this COVID stories that have been going on, but it's still very important. We have a great guest coming up to talk about this. But first, just a couple of announcements from the Ohio Academy of Family Physicians. First, I want to remind everybody of a CME live webinar coming up on April 22nd from 7 to 8:30, entitled Challenging Race-Based Medicine in Practice. We have a great speaker for that session. You can register at ohioafp.org. Again, that's April 22nd, starting at 7 p.m. And secondly, as I say with every show, yes, we have merchandise. We have the merch. You can go to ohioafp.org. You can get cool masks that have things like COVID vaccine check on it. We have these great shirts that you've probably been seeing on social media. Proud to be a vaccinated Ohio Academy of Family Physician. And proceeds of that go to our foundation, OAFP Foundation, whose mission is to cultivate student career choice in the specialty of family medicine. So before we begin our guest, I do want to give him a proper introduction. Our guest coming up is Dr. David O'Gurek, MD, FAAFP. Family physician from Pennsylvania. Dr. O'Gurek practices comprehensive outpatient family medicine, as well as serves as the medical director of the Trust Clinic, an office-based opioid treatment program for patients who have opioid use disorder. He also serves as director of Begin the Turn, a community-based multidisciplinary mobile care unit serving patients with opioid use disorder and homelessness in North Philadelphia. Notably, he partnered with the City of Philadelphia and its agencies to address the overdose crisis. He's former chair of the AAFP Commission on Health of the Public and Science and former board chair and president of the Pennsylvania Academy of Family Physicians. And welcome to our guest, Dr. David O'Gurek. So, good evening, Dave. Thank you so much for the time tonight and speaking on this very important topic. Thanks for being here.
Good evening, Mike. Thanks for having me. I'm delighted to talk on the topic. I know we have a brief time, but I could probably talk for hours on the topic. There's only a lot to talk about.
Exactly. And you're known as a national leader on this. I remember seeing you speak at FMX maybe 2 or 3 years ago on this important topic. I know you're very involved locally and regionally and nationally. Before we talk about what family physicians can do to help their patients, I wonder if you can just set the table for us as far as the seriousness of the problem, what your experience has been, especially during this opioid crisis.
Sure. It's definitely a significant issue. I think it's not news to anyone in terms of the experience, both within our home communities. There's certainly not a community across the country that hasn't been affected by the overdose crisis. There's obviously many challenges, and sadly, there's no sort of single approach that's definitely going to address the problem. In terms of language and terminology, setting ground rules from the start is important. When we're speaking about the crisis, generally, I like to refer to it as an overdose crisis, and I'll talk a little bit about why that is. But really, we've had an opioid crisis for years. Certainly, within the recent years, there's been heavy rates of overdose deaths related to opioids. But I think more practically, with where things have evolved over time, we're really dealing with a drug or an overdose crisis. And thinking about sort of the parallel COVID pandemic and seeing sort of what has occurred, we don't have the official data from all of 2020 yet. But seemingly, it seems like with regards to overdoses, it's definitely going to be the worst year that we've had. From the CDC, looking at 2020, looking at a 12-month time frame through May of 2020, there's over 81,000 drug overdoses that led to fatalities, which is the highest in a 12-month period that we've ever seen. And as we look at that, a large percentage of the overdoses certainly were related to fentanyl. So initially, as we talk about opioids, a lot of the focus, and I think some of the discussion tonight is certainly going to be around prescription opioids and how that can potentially affect the overdose crisis and perhaps has contributed to that. But definitely when we look at heroin now, most of the heroin that's out there is not heroin anymore. It's really fentanyl, and over 3/4 of the overdoses that occurred in that 12-month time frame were fentanyl related. But we also see rises and significant increases in overdose deaths related to other substances, notably cocaine, as well as psychostimulants. And psychostimulants has actually overtook pure heroin nationally as looking at being related to overdose deaths. Looking specifically at Ohio for the Ohio Academy, the 2020 data, again, isn't available. A lot of that gets delayed just because of medical reports and sort of the reviews that occur. So oftentimes the last quarter doesn't come out till well into the subsequent year. But looking at 2019, over 4,000 overdose deaths. And again, similarly seeing high rates of fentanyl, high rates of psychostimulants with methamphetamine and amphetamine. And certainly as we're seeing sort of people dying, sort of there's often polysubstances. So as a crisis, we're really dealing with a drug crisis and an overdose crisis where multiple substances are on board and has been affected. That has its sordid history with it. Certainly, as I mentioned, we've had an opioid crisis for decades that wasn't really acknowledged, and certainly evident perhaps in communities such as communities, poor communities or people of color, that there wasn't a lot of attention put on the issue. Not to say that sort of it was higher within people of color, but definitely sort of some of the deaths and the challenges that existed weren't paid attention to largely because of that. And I know you mentioned we have a conference coming up on race-based medicine, and I think such an important topic and sort of really weaves in with this, particularly looking at our sordid policy history of how we've handled sort of drug policy just as a country and as a people with sort of legal approach as opposed to looking at sort of a more comprehensive trauma-informed approach.
Yeah, I mean, I can share that, in my home county here in Northeast Ohio, part of our county probably is considered, Appalachia or Appalachia-like, and people nationally kind of know what that means. And we've had some, unfortunately, stories nationally that have come from this county as far as some of those tragic type of stories. So and before COVID, I mean that was a big medical story nationally, and it's still out there, and all of us family physicians kind of are still experiencing that with our patients, and so I guess kind of talking about what family physicians can do, and the AFP has this great resource called the Chronic Pain Management Toolkit, and we'll put up a link on that for people who are watching this either live here or later for people who want to access that. I guess kind of just talking about this, talking about this topic, Dave, just kind of maybe you can just outline the toolkit in broad strokes, and then we can kind of dive into more specifics.
Sure, and the toolkit certainly has been a fantastic resource, I think, both for family physicians as well has been shared nationally with other organizations and people within the policy world to show the work that family physicians have been doing. We're seeing certainly with the numbers and looking at the overdoses, despite us seeing overdoses increasing in many places, we're seeing overdoses sort of related to prescription opioids decreasing. in a sense, and some of that may in fact be related to opioid stewardship that's put in place largely around the management of chronic pain, and paying more attention to that. We have to make sure, sort of, I think, as we're doing this, the Academy has tackled the overdose crisis in many different ways, but with opioid stewardship in and around the treatment of chronic pain, while they're interwoven, the notion that we need to make sure we're delivering evidence-based care that appropriately treats chronic pain and doesn't leave patients that are experiencing chronic pain out to dry just because of sort of increased attention to don't be prescribing opioids and those sorts of things. So this is an updated rendition of the chronic pain toolkit that's been around for a number of years now, but again, is a great resource, certainly even for practices that have protocols and systems in place, that really shares good resources to understand how to evaluate chronic pain in the office with some standardized tools to make sure that we're doing it in a comprehensive way. And being able to have that upfront discussion with patients sort of about the notion that our goal cannot be, and probably isn't, that we're going to get complete cessation of pain, but we're going to focus on functionality. And because we haven't necessarily had a great deal of education on how to completely assess that sort of in an office setting or just in general, there's great tools out there to really understand sort of what functionality is a patient looking for, what functionality have they lost, and for us to get a better sense of how chronic pain is affecting their life.
Yeah, I mean, if I could jump in, I mean, that is a great point there, Dave, is that, I remember training, and then we never got any kind of formal type of training on this because, who would have known that it would have been such a crisis? You use the words opioid stewardship, which I think is a great phrase to use. And another thing that you brought up there is that a lot of these discussion points, recommendations are evidence-based. So family physicians, AFP members, or even legislators or policymakers can really use this as a resource when looking towards making policy recommendations. I suppose that's not done by accident by the Academy and by other entities.
Certainly. And it's just important. I think the Academy in general is very mindful about making sure that the messaging that they're putting out is rooted in evidence, but also sort of appreciates the patient-centeredness that needs to be delivered here. Largely because the existing frustrations and the toolbox in certainly eloquently put within it, but also it's not being promoted as a sense that it has all the answers either, because chronic pain is still a black box for people experiencing it, for physicians that are treating it, for the clinician community in general. It's still challenging, and the toolkit highlights the challenges within there. That while sort of the evidence suggests from a pharmacologic standpoint, we should be using non-pharmacologic or non-opioid pharmacologic agents first. Again, with the focus being on pain, there's a nice chart that looks at the evidence and looks at sort of both in terms of pain as well as functionality, the limited evidence even on the pharmacologic tools that we have available and what they do, on a population-based schedule for individuals experiencing chronic pain. So there's challenges. The toolkit sort of, I think in a very real way, and as I look at it, it really helps members of the Academy sort of experience the journey of chronic pain with their patients, which I think is so critical. There's so much sometimes that guidelines and processes, we do to people, where we're not doing with people, and experiencing that journey and going along with them. It's such the essential role of what we do as family physicians and comes natural to us. And this just puts it into a context with some helpful tools to be able to do that along the way.
Now we're not going to go through page by page here. We're just going to just kind of paint some broad strokes, and people obviously can check the link out below for the pain kit itself. But I guess in generalities, how would you describe, the assessment process as far as pain assessment and functional assessment? What are family physicians, really trying to do in these initial stages of the evaluation?
Yeah, I think it's trying to understand from the patient what their chronic pain experience is like. Not only identifying sort of, the typical things that I think we would do as part of the evaluation, but that expansion of understanding sort of functionally what's limiting, what are the goals sort of for functionality with where perhaps we're going to go to, which really sets the stage for the treatment and what the best treatments might be and understanding the evidence. And the tools that are there, sort of there's the brief pain inventory, there is, more comprehensive functional assessments that are questionnaires that, as you think about these things, some of them may already be integrated into electronic health records. In a very real sense, I think sometimes when toolkits like this come out, or there's sort of guidelines that come out, our physicians respond with, wait, you want me to do one more thing? You're asking me to include one more thing into sort of this busy visit.
Yes, yes.
That's just not practical. In a very real sense, the toolkit provides resources that shows this really needs to be a team, and sort of integrating some of these things into workflows that, before you're even in the visit, sort of the brief pain inventory can be completed, or the functional assessment could be completed, that, with someone in the office, and even getting like a champion within your practice that's sort of going to, be in charge of this, sort of work on integrating this into workflows, making sure that they're the person overseeing other staff, doing some education. That doesn't always need to fall to the family physician in the office. Certainly sometimes it's best that it's not us, particularly asking these questions, because we know our patients sometimes open up to our medical assistants, to our nursing staff about these things much more openly than they do, particularly with us, at least initially. So we get valuable information right up front in terms of integrating these things into the workflow. The other pieces of those that could be, again, done right up front, there is a risk tool. If we're thinking about using pharmacologic therapy with opioids for a patient with chronic pain, sort of doing a risk assessment and understanding sort of, is this a patient who maybe is considered at higher risk sort of for the prescribing of opioids. And in a very real sense, I think, that gives us sort of a sense of things, but it doesn't necessarily dictate what we do or do not do. Ultimately, we have a patient sitting in front of us who's experiencing chronic pain and is suffering, while that risk tool sort of creates an understanding, perhaps more comprehensively, of the picture of this patient. Have they experienced, traumas before? What has their past history, as well as family history or community experience, have been like, that have affected them in a certain way that make them perhaps at higher risk of developing a substance use disorder? We know that things like adverse childhood experiences and past trauma put individuals at higher risk of developing a substance use disorder. So does that mean that we shouldn't be prescribing opioids to those individuals? No, but I think we go into it in a much more informed approach, that we have a bigger comprehensive picture to understand the treatment plan a little bit better as a team with the patient, again, not to them.
No, I'm so glad you brought up time management, because I hear that feedback as well. And I guess in this age of COVID and telemedicine and things, are these questionnaires, do they lend themselves to patients doing them at home, or are they not as accurate, or one of your team members, maybe doing a phone visit with them soon, doing some of these evaluations? Does that compromise the data at any time?
Yeah, that's a great question, Mike. I think, many times these tools are meant to be completed by the patient sort of on their own time. And, some of them, the language isn't necessarily written to an appropriate level considering health literacy. The tools that are in the toolkit are pretty well sort of understood, that they're written at a health literacy level that would be understanding for all patients of all ages, because certainly chronic pain exists in a pediatric or adolescent population as well that we need to be considering. But, oftentimes sort of you're going to get better answers, and the tools have been actually validated from an evidence standpoint with the patient completing them themselves, as opposed to it being administered by someone in the office. So with telehealth, while it throws a snag into some of these things, they are things that if you can send them to the patient ahead of time, or that again they're available for the patient to complete through a virtual platform somewhere ahead of time, it's something they can come prepared to the visit for if it's going to be a telehealth visit.
Now, there's a whole section, Dave, devoted to chronic pain versus acute pain. Can you break that down a little bit? Why it's important, and how you try to distinguish between those two complicated yet similar type of concepts?
Yeah, I think clearly when we look at evidence and we look at information that's available, and even helping us have conversations with our patients, and again with legislators, with policymakers, with the general public health community, we know a lot more sort of in the sense around acute pain than we do with chronic pain. And in terms of, clear evidence of potential harms of utilizing opioids too long in an acute pain situation, as opposed to utilizing other mechanisms sort of for treatment. If we're using non-opioid pharmacology, it's critical. In that real sense too, sort of if we have a good understanding of acute pain and understand what it means, and working with patients along with functionality and those sorts of things, the goal is to prevent someone from transitioning from an acute pain condition to developing a chronic pain condition. And the pieces of that are interrelated, because some of it is the same type of pieces. Some of those traumas, some of that psychological history and things that may affect things are the same principles that we need to look at and evaluate from, again, a trauma-informed lens to understand how to prevent someone from transitioning to a chronic pain state. Now, can we completely do that? Probably not for everybody, but I think in certain individuals, there are windows of opportunity to perhaps intervene in an earlier fashion, or have, conversations to sort of shape some of the psychological approaches to pain as well, for both, the patient as well as their family, to avoid heading towards a chronic pain state.
So getting to the next section, as far as opioid prescribing, I know a lot of our colleagues just kind of jump to that and say, what can I prescribe? But before we talk about that, and we do have some graphics to show the audience, why don't you describe a little bit, and you did talk about a little bit before, as far as guidelines for opioid prescribing. Can you kind of go through those a little bit, and then we can dive into specific treatment regimens?
Sure. So, again, and this is getting back to sort of our initial conversation, obviously with the overdose crisis and the initial focus that was clearly largely and understandably focused on opioids, there was a lot of attention on looking at the negative effects of prescribing opioids, and how that perhaps contributed to both development of substance use disorder as well as overdose, both fatal and non-fatal overdoses within the community. And as a result of that, there were many things and sort of just rash decisions that sometimes happen from a policy perspective, but also guidelines that came out that looked at the evidence and clearly showed that evidence is lacking for sort of utilizing opioids for long-term chronic pain. And the risks in those studies sort of suggested that they significantly outweighed the benefits. And, we had the CDC guideline come out, and then sort of revisions of the CDC guideline around that. Many states, some states had developed their own sort of guidelines. Health systems for employed physicians may have developed guidelines for utilization of opioids in the management of chronic pain. Again, some of them have good evidence to them, some of them may not. And it does get tricky, because it's again a little bit of a black box where we completely don't understand, but there are some things that sort of seem to suggest they should be put into practice, and they reduce some of the negative risks associated with utilizing opioids for chronic pain. So the toolkit, very appropriately, I think, points out from the beginning on the section that there are patients with chronic pain who may be on opioids or who may utilize opioids for their treatment. And you may see improvements in functionality for those individuals. And if things are going well and there doesn't seem like there's any problems, and the toolkit sort of has some information sort of looking at, again, potential risks or potential signs of opioid use disorder that you need to be wary of when you're prescribing chronic opioid therapy to someone for chronic pain or other conditions. That it's not to say that we shouldn't be doing this. And in a very real way, I think we need to be mindful of that, because when all of this came out, there really created a lot of tension and friction, particularly between the medical community and the community that experiences chronic pain, that suddenly the community that experiences chronic pain, a lot of people may have been feeling like they all think I have substance use disorder, and not utilizing that language, using more stigmatizing, marginalizing language around that. And I think it's really critical that we acknowledge that that's not the case. And in our opioid stewardship conversation, sort of, we're understanding that we're just trying to do what's best for the patient in front of us, as well as avoiding harm using the best evidence that we have available, which again isn't that great. And the toolkit appropriately outlines that. But it gives us some guidance for when we're using opioids, sort of signs to look out for, as well as some risk assessments, and then tools that could be implemented sort of into your practice that help monitor for some of those negative side effects and things. While we know, anyone that's going to be on chronic opioid therapy, I think from the start, we just need to understand that if you're on chronic opioid therapy long enough, you'll develop tolerance, you'll develop dependence. Neither of those alone are substance use disorder. And clearly acknowledging that there's a distinction between those two as well, and being upfront about that, and not jumping to conclusions when those things happen for some of our patients.
And I know from a state-by-state standpoint, I know especially here in Ohio, our state legislator has laid out, the appropriate documentation to put in the chart as far as, I've assessed this patient, qualifies, or I think would be appropriate for chronic opioids. I know different states have different documentation requirements, and I know as people watch this, you should also, in addition to this kit, obviously check out your own state laws as far as to make sure that you are in compliance with your own state, because we have all known physicians who are out of bounds with that, or you've seen the news reports of physicians who are doing this inappropriately. So in addition to this toolkit, obviously follow your state laws. Is there other things that we would need to document before we kind of just dive into this treatment thing, before we dive into that, Dave?
Yeah, I'm so glad you brought that up, Mike, because it's such an important point. There are variations by state laws that clearly no toolkit or guidelines going to be able to completely address. And it's important, I think, for members to be aware of what their state laws say in and around those sorts of things. I will say some of the toolkit specifically has a feature with a pain agreement. Sometimes people refer to them as pain contracts. And I do know, sort of just in Pennsylvania in general, and just some of the requirements institutionally that people are looking for within a pain agreement, the toolkit may not have all of that. So simply just taking some of those resources and implementing them into your practice, you're going to need to look at your situations, whether it's your health system, whether it's your local or your state government, or there's other factors that are important to implement in addition to those tool features.
And I don't know how many states that they have them, but I know here in Ohio, we have a state registry system, and here in Ohio, it's called ORS. And I know that that's a requirement for that to be checked and for you to report that to the state. And I know a lot of states probably have that requirement as well. So Dave, why don't we just kind of dive into things here? Well, I'm going to ask Caitlin to put up the table here, the opioid conversion table. which I think is page 31 there. So people need to see us. They can. This table is more important to see. Can you break this down a little bit, Dave? Because I know that I get very confused when I'm talking about chronic pain and these medicines that have longer half-lives and things. Can you break down this table for us?
Sure. So, the table as a whole is a great resource that has a lot of information on it that you may or may not need. Really, for your opioid conversion, the conversion factors converting to morphine milliequivalents, which is the MMEs, is really the only column you need if you're really just going to do a conversion. The dose equivalent might help you, and I think it might help if we walk through the sample case to actually show sort of how this plays out.
Great.
So if you have a patient that's 45 years old, taking oxymorphone 10 milligrams 4 times a day for chronic pain, and you say, well, you're on this 4 times a day. We would like to convert you to a long-acting regimen, and we'd like to use extended release oxycodone. So the first step for any of your patients is to transition to what the total daily dose is really at this point in time. So if they're taking oxymorphone 10 milligrams 4 times a day, it's the 10 milligrams times the 4 times a day. You have a total of 40 milligrams per day of oxymorphone. So if you're going to look at converting oxymorphone to an oxycodone equivalent, you're looking at your conversion factors. So the first step with what the sample case is showing you is how to convert that dose that they're taking of oxymorphones to MMEs, and then convert those MMEs into an oxycodone dose. So we're going to do this the long way, and then after we're done, I'm going to show you the quick way to do it as well. So converting to MMEs, so 40 milligrams of oxymorphone, the conversion factor is 3 to 1. So for every 1 of morphine, it's 3 of oxymorphone. So converting 40 milligrams of oxymorphone to morphine milliequivalents, it would be 40 times 3, which is 120. So then now you have 120 morphine milliequivalents. So what does that look like for oxycodone? So for every 1 of morphine, it's for every 1 of oxycodone, it's technically 1.5 of morphine. So to convert the MMEs back to oxycodone, instead of multiplying here, you're dividing, because actually the oxycodone is more potent than the morphine. So you're taking the 120 morphine milliequivalents divided by the 1.5, and you get 80 milligrams per day. Now you may be looking at this and you say, okay, well, that seems really confusing, and there's definitely an easier way to do it. Because if you look at your chart at the dose equivalents, really, so 10 milligrams of oxymorphone in the dose equivalent column is 20 milligrams of oxycodone. So essentially you would say, okay, any oxycodone dose is just going to be double of what the oxymorphone dose is. So if I'm taking 40 per day, you just multiply by 2 and you get the 80. So you don't have to do that conversion to morphine milliequivalents and then back into the other thing. One of the tricky things is if you don't have a clear ratio. With this conversion chart, most of the ratios are pretty easy. They're going to be 2 to 1, 3 to 1, 4 to 1. So it's quite quick that you can do that. If you're converting from an IV dose to an oral dose, there are other conversion charts, particularly for those that do inpatient medicine or are doing hospice and maybe are converting from IV to oral. There are other conversion charts that are available. But for this, basically, 10 of oxymorphone is 20 of oxycodone. So you could just take the 40 per day and multiply it by 2 and you get 80. Now, a general rule of thumb when you're switching sort of from one morphine, equivalent to another is for cross tolerance within the individual, you would reduce the dose by about at least 25%. So what they're saying now is, okay, we have 80 milligrams per day really of oxycodone, but we want to reduce that by 25% or a fourth, which would be 20 milligrams. So you take that 20 milligrams off the 80 and then you have 60 milligrams. So if you're going to prescribe extended release oxycodone, your total daily dose is going to be 60. So if you do extended release, you would take 30 milligrams twice a day.
Okay. Okay. All right. Yeah. Yeah, I'll have to go over that a few more times there, Dave. I mean, it's just
Yeah, no, it's definitely.
And I know that, and a lot of my colleagues have showed me that there are some, cool smartphone apps that can kind of do that more quickly. But it's always good just to kind of go through that, just to kind of go through the theory of all of that, because it obviously it is very tricky to switch from an immediate release to a long-term release, because you want to be very careful with that. I mean, would that be fair?
Absolutely. And I think your reduction for cross tolerance is always something that you want to be mindful of and be thinking about. I don't know what happens when you get older. Like, I feel like I used to be so good at math, and I used to in my head. Honestly, when I was preparing and thinking that we were going to go through this, like, I really needed to sit down with a pen and paper and write all of this stuff out. And if you write it on paper and sort of do your ratios and even write out like the words oxycodone, oxymorphone, and you're able to cross those things off with your ratios for people who liked algebra or who once were good at algebra but forgot all of it, it does make sense. It's just, it can get complicated, particularly, again, if people are transitioning from the hospital to sort of the outpatient setting or from IV to oral. It's always good to run this conversion factor and see, because many times people are getting certain doses of IV in the hospital, and then they're discharged and resumed on a previous dose or resumed on a dose, and they're having a lot of pain, and people have questions, well, like, why? But when you run the conversion, clearly they were getting much more in the hospital than they're getting now. And now we have an understanding for why. Like, you were needing more IV in the hospital. We converted what you were getting IV to oral. And it's just not enough.
Right.
And, again, the toolkit doesn't have an IV to oral conversion, but I can get you some resources that you could share with people as well that have those opportunities. But as you mentioned, I think apps on the phone or even some of the conversions that are within the computer that can do it for you without needing to use, again, that part of math of my brain that somehow went away, are quick ways to do them as well. And they'll even figure out some of the cross tolerance reductions for you as well, some of those calculators and those app tools.
Now, after you would start this long-acting agent, then what does the evidence say, or what does practice say as far as when to reevaluate these patients?
Yeah, I mean, it's in terms of the exact of what's right and sort of reassessing people. I do think it's always good with a dose change to check in with people a couple days afterwards, just with a quick phone call, how they're doing. And again, this gets to it being a team effort, that doesn't necessarily need to be sort of the physician calling. It certainly could be somebody from the healthcare team that's calling just to check in on somebody, sort of with a scripted series of questions. Definitely within 5 to 7 days, just sort of a good check-in sort of with how things are happening. And then a lot of times you're bringing people in sort of monthly for prescriptions or those sorts of things. You may choose to bring them in a short period of time, sort of for another prescription that you're just writing a short dose of medication. Certainly considering, particularly with higher morphine milliequivalents, considering prescribing naloxone with opioid prescriptions, or just as a general rule of thumb, honestly, co-prescribing naloxone with any opioid prescription that you write, just so that people have that and understand why you're doing it, and just that they have access to it. And making sure that they have information that they can inform family members that they have it or that it's there, and those circumstances. And then obviously other types of things that are important with changing doses of opioids in terms of driving, or assessing sort of if people work and sort of what's involved in their work and some of the drowsiness that may occur, and whether or not they should be operating a vehicle or heavy machinery with a change in dose are things we need to be thinking about.
Our time is going by very quickly. I did want to get to the topic of tapering. and that's page 33 in the toolkit. And before we kind of go over the table, just kind of go over the concept of tapering and the important things to think about, and then we can dive into the table, especially with the symptoms, which I think are very important.
Yeah. So tapering's tricky, and the toolkit certainly has information that's helpful on how to perhaps address this topic, suggestions about how to do it. If you taper one person, you taper one person. All of them look very different. I think in terms of tapering, you need to make a decision sort of with why you're tapering. And oftentimes it needs to be a collaborative discussion with the patient. So, patients that come in and sort of want to come down or want to come off their chronic opioid therapy, there's opportunities there that the door's open for that discussion. But there are other individuals where maybe we need to come down, or maybe there's insurance issues or things in the pipeline. We know that there's going to be circumstances where individuals are going to be forced to lower their dose. And we need to be advocates for the patient in that perspective as well, making sure, particularly those that are doing well on their current dose, as the toolkit points out and the Academy resources point out, there shouldn't be forced tapering for individuals that are doing well, that are experiencing functionality with their pain and not experiencing any of the side effects. The key is, again, really that trust and relationship that's built with the patient through the pain treatment process. And it's so critical that you start that even before you would start an opioid or as part of the process of treating chronic pain. So knowing that from the beginning and having them trust you to be able to recognize and acknowledge that the process is going to be a joint effort, and a we, and not a I'm going to be doing this to you. So generally coming down slow and steady over time. And, giving people room that if they're coming down and sort of it's not working, maybe there's still that window that we could go back up. Like, it's not, this is going to be the schedule. We're going to bring you down 5% every week or every month or 10% every month. And if we get to a point you're experiencing sort of loss of functionality and problems, then we still continue to come down. We can't leave the patient out to dry, and we can't leave them high and dry in this process. Now, obviously, if there's other things that are identified in terms of if someone sort of is identified as having opioid use disorder, as family physicians who, have, sadly, we could prescribe all the opioids we want, but we need to take an 8-hour course to be able to prescribe buprenorphine. Having that waiver and having that ability when we identify someone having opioid use disorder to transition them to treatment for opioid use disorder with buprenorphine. And while it's not approved for the treatment of chronic pain, recognizing that we can share with patients that it actually will help their pain in some capacity as well. So while we're treating the opioid use disorder specifically with the buprenorphine, that, we're not leaving them out of, comfort or functionality. That's still going to be part of our goal and part of our treatment. We're just doing it in a different way.
So I'll ask Caitlin to put that table up, and you don't have to go through brick by brick here, but maybe just what are kind of the highlights with each of these stages, which I think is very important in some of the treatment options.
Yeah. So these are things to be aware of, and I think things to certainly there's handouts you can give to patients as well about signs of opioid withdrawal and how quickly they may experience these symptoms. And particularly as we're lowering a dose, even with going slow and lowering 5 to 10%, people may experience some of these symptoms depending upon the dose that they're on or depending upon how long they were on that specific dose. So, with tapering or lowering doses, knowing sort of when they would experience these symptoms, what to watch out for, and sort of why. Some of them are, some of them are very objective findings that people could see. Some of them are a little bit more subjective type of findings. Some of the anxiety, a lot of people just in general around the tapering process are coming down, have a lot of anxiety. So, while it's not coming about really to that post-acute withdrawal syndrome that's happening sort of after the acute withdrawal in the 7 to 10 for a while afterwards, a lot of this is sort of really, you see it more with rapid removal of opioids. Can you see it with slow tapering? Yes. But it's also a gauge for you as well to know perhaps you came down too fast or the patient came down too fast, and sort of guiding them through it. And it's not dissimilar to sort of the way we think of preoperative assessment or preoperative sort of management, or talking about pain that will happen with a surgery and how we're going to manage that post-op, to kind of understand that some of these symptoms you may experience, and if they're happening, what opportunities we have or what medications they may be able to take or have on hand to help with some of these effects.
And I guess my last question in this section is, I mean, the toolkit does describe the role of urine drug testing. How do you recommend family physicians utilize that in their practice?
Yeah, so I mean, I think you need to be aware of your test, the limitations, as well as the benefits. There are definitely a lot of point of care tests that are out there that have different sensitivity, specificities, different mechanisms for how you can test. You can do urine testing, you can do saliva testing. The urine testing, by and large, seems to be a little bit more sensitive and specific than the saliva testing. But it maybe is a little bit more practical to do the saliva testing depending upon where you are, the setting, or if you're in a mobile clinic or you don't have a bathroom nearby. General clinics have bathrooms, but if you're sort of doing street medicine, you may not have that accessibility or the privacy to do that. I think a lot of times insurance and processes will dictate how frequently you need to be doing a urine drug test. I think what's critical about your urine drug test is how you're using it and what you're using it for, and recognizing that it is a tool. It is not the foundation of doing chronic pain treatment with chronic opioids. So you may be looking for, just consistently checking for what they're taking. And for that purpose, sort of, do you need sort of an 11 drug panel that you're looking for everything? Maybe, maybe not. Maybe you just need a test that sort of tests for either morphine or the synthetics like oxycodone. Or if you're prescribing methadone, for pain treatment, obviously sort of having a methadone test that's there. Be careful with how you manage and handle the results of other things. So, someone comes up positive for cocaine. Okay. I mean, does that mean they have cocaine use disorder? No. Don't jump to conclusions, sort of understand what's happening. There are certainly false positives with point of care testing. Now, the things that go to the lab, the much more expensive gas chromatography, those things generally don't have false positive rates that are concerning in that nature. But use them as a tool to sort of understand what's happening to the patient. Did they show up? Was there an issue that they couldn't get in on time for their medicine and they were really struggling and they were having a lot of pain, and this was the first time they ever used cocaine, and now they want to be better. Is that a reason to sort of say, well, I'm never prescribing to you again? I think each physician sort of needs to decide for themselves how they're going to handle those circumstances or situations. Sometimes the all or nothing type of thing isn't really helpful sort of to the larger patient picture of things. And if someone sort of is showing positive for another substance, we may identify another substance use disorder and be able to provide access to treatment for those other opportunities. So use it as a tool, use the right language around it. A lot of people will say things like dirty urine, which isn't a very helpful, it's certainly a stigmatizing term. Oh, their urine was clean today. I don't know what that means. Either the test was positive or it was negative. Either what we were looking for was in there or it wasn't, or there were other things that were in there. Sort of the clean, dirty terminology isn't patient-centered, and it doesn't help things, or it certainly breaks down some of that trust and relationship we have with our patients.
Dr. David O'Gurek, I mean, thank you so much for your expertise. I know you could talk for hours on this, but I guess to finish up this conversation, you have closing thoughts for our audience, closing thoughts about this very important topic for family physicians and for the nation.
Yeah, I mean, if I can share, I guess, just maybe 2 or 3 points. chronic pain management is still, as I said, a black box. It's tricky, and I don't consider myself an expert. We're all sort of wandering out in the wilderness when it comes to this, and you sort of do what's best for the patient in front of you, and do the best you can with the resources that you have. And this notion of never prescribe opioids or NSAIDs first. Sometimes those campaigns are frustrating and sort of aren't helpful. I think in terms of the bigger picture for the overdose crisis, certainly opioid stewardship's a piece of the solution. If you don't have a waiver, please obtain your waiver and implement buprenorphine prescribing into your practice. As a family physician, I feel like it's one of the easiest things that I do. And it's so rewarding and has taught me about ways to be a better family physician. And make sure you're prescribing naloxone, carry naloxone, talk to your patients about naloxone, making sure they have access to that and provide those services to patients.
Great. And before we close things up, I do want to thank the American Academy of Family Physicians for the grant and part of the Ohio chapter's, deliverables is to disseminate the information about this toolkit, which I think is very important. And of course, thank you to Dr. O'Gurek for your expertise and your passion for education and for all that you do. So thank you so much for the time tonight.
Thanks, Mike. And thank you to the Ohio Academy for having me and sharing this really important topic.
That ends this session tonight. You can see all the archives at ohioafp.org for our past topics, and we will have more topics coming up. So that ends our program this evening. Have a good night, everybody, and we'll see you all next time for Bite Size Learning.